The misconception from whoever's writing the order, may it be the physicians or the nurse practitioners, the misconception is that everybody who walks into the hospital needs a physical therapy consult. And that's not true. They may need to be mobilized, that's for sure. But again, you have to think about, is it mobility that they need or do they need rehabilitation? I've had multiple examples where I will walk in and the patient has been admitted maybe in the morning and I get to them in the afternoon, and I walk into a patient room and the patient is standing brushing his teeth and the nurse tells me he's done 4 laps around the hallway. And my thought is, why was I consulted for this patient who is clearly independent on his feet? A perfect example of a physical therapy consultation would be physical therapists to assess patients' discharge needs. Do they need an appropriate assistive device to go home? If we're taking the time to address orders that are not appropriate, then we cannot get to the patients who actually need our services in order to assist the team in getting them either home or getting them to the next level of rehab. So we're having to prioritize and are oftentimes unable to get to the patients that actually need our services.
When it comes to rehab, oftentimes everyone thinks of physical therapy, which is not the case. I try to really mention to my patients, the family members, and rehab is a team. It's not just physical therapy. I really worked hard towards making sure that I introduce myself as an occupational therapist, sometimes a little more loudly and boldly. Example I have is when I was working with a patient who's had hip surgery. I'm using a reacher, grabber, whatever you want to call it, helping a patient be able to get dressed independently in the modified fashion. Physician comes in and said, "Oh, I see you're working with physical therapy." Right then and there I have to make my corrections. "Oh, this is occupational therapy." Those are perfect examples of physicians who need to understand the importance of being able to identify the differences between the two. And if, in fact, we can change the terms to be rehab, it will go a long way.
No, it's not actually true, but we do hear that we don't want to refer to speech because they'll make them NPO. And that's really not true, because what we really want to do is allow patients to eat safely and comfortably. So they don't always say it directly. Sometimes you hear it through the grapevine that we're not going to make a referral to speech, or they'll put a referral into speech and then they DC it because they don't want us to go and make the patient NPO. So I would try to approach that physician and say, if you allow us to work with your patient, we will work with them, provide education to the patient and the family so that they can eat the least restrictive diet, educate them so that they're aware of the risks, and then go forward from there.
Physical therapists are not needed necessarily to just mobilize a patient. The nurses can mobilize, the RNs, the CNAs. Mobilization is a team effort. So one of the misconceptions is that a patient cannot move unless they have a physical therapy consultation. Whenever an order is written that says PT to mobilize, that is oftentimes construed by the rest of the team that only PT can mobilize this patient. And what can happen is then the patient is laying in bed for longer than the patient needs to be laying in bed. And I ask them if they've been out of the bed with the nursing staff, and they say no, because we were waiting for a physical therapy consultation. And then the patient is able to get up with very minimal assistance, and I wonder why they haven't gotten up. A great order to write would be, if you want your patient mobilized, is out of bed for all meals, ambulate with nursing staff, TID. These are really good general mobility orders so that the team knows to get the patient up and get them moving.
So the misconception is that there's nothing we can do about mild cognitive impairment, when in fact there is a lot we can do about patients that have mild cognitive impairment. So there's one particular example of a patient. He appeared to be functioning at his baseline. He was very friendly, very interactive, very funny. But working with him, I realized that when things got a little bit more complicated, he wasn't able to recall things, he wasn't able to follow through on complex directions. So I noted one day the medical team were doing rounds, and I just approached them and said, hey, this patient, I have some concerns about him. He's planning on going back to work. I feel like he has some mild subtle cognitive deficits. So make a referral and listen to other nursing staff, other therapists, occupational and physical therapists who may identify that there's a cognitive impairment. So identifying this early and providing treatment maybe while they're in the hospital, and then maybe follow up outpatient treatment so that they can go back home and they can go back to work slowly and gradually, but with the support of therapy so that they can do it successfully.